Well, next up, we're going to be talking about stable angina or ACS, chest pain, starting with history. Three components of angina: substernal chest pain that we're talking about, low risk, intermediate risk, and high risk. That's usually brought on by stress or exertion and relieved by rest. So these three: substernal chest pain brought on by stress or exertion and relieved by rest. If it's 3 out of 3, this is typical chest pain. 2 out of 3 is atypical, and 1 out of 3 is usually non-cardiac. So history is always most important when assessing these patients with stable angina or ACS. You can use anti-anginals for treatment, nitrates. Again, it's always important to look for comorbid risk factors, avoidtive, preload sensitive history of aortic stenosis. You can also use beta blockers. Of course, careful if there is a prolonged PR or AV block. And you can also try calcium channel blockers if patient is beta blocker intolerant. So low risk patients, this is the likelihood ratio for ACS seen in JAMA article 2015. You can see pleuritic chest pain or syncope. These are low risk patients. Intermediate risk is when the chest pain radiates to the left arm, neck, or jaw. A patient presents with comorbid diaphoresis, pressure or typical pain, or pattern change in the past 24 hours. High-risk patients that have previous ischemia and that report the symptoms similar to that of prior ischemia, pain radiating to both arms, concomitant known peripheral artery disease, or abnormal prior stress test as well. So all these patients are categorized as high risk as well. On physical exam, these patients with stable angina or ACS can have a new S4 or new mitral regurgitation, and this can indicate ischemia. New CHF, you can see crackles S3 or increased jugular venous pressure, which is the most specific, pedal edema. You can also auscultate carotid subclavian and abdominal bruits, can indicate other vascular disease. Less likely ACS, as we talked about before, the low and intermediate risk. The 4 P's: pleuritic, positional, reproducible by palpation. So all of these factors are important to take into account when assessing these patients for low, intermediate, or high risk ACS. Next, we'll be talking about acute aortic syndromes, acute pericarditis, PE, pneumothorax, pneumonia, and other, to kind of go throughout the differential of chest pain.